stage for a very interesting keynote address, Dr. Audrey ROSTOV, who comes all the way from the beautiful city of Seattle, and she's going to be talking to us on managing complications in SMILE and LASIK. Welcome to India, ma'am.
Thank you so much. It's always a pleasure to be here. And thanks to everybody in the room. We've got the few and the motivated here. I'm going to be discussing management of SMILE and LASIK complications. No relevant financial disclosure. When it comes down to a very basic level, what do patients want? They want two things, no matter what type of surgery you're doing. We all want great outcomes, and we all want to have the safest procedures. There was a really nice article in JCRS, the Orange Journal, that once again showed that there's essentially equal outcomes for LASIK, SMILE, and PRK. So whichever method of laser vision correction you choose, you can be reassured that your patient will have an equal outcome. When I think about SMILE, LASIK, and PRK, I think about it like this. I do, when anybody is a candidate for any of the procedures, I tend to do SMILE since you preserve more corneal integrity without the flap and there's less dry eye. LASIK, however, is my favored for cases of higher astigmatism, very low myopia, or if there's a corneal scar that wouldn't allow for a good SMILE procedure. And I really reserve PRK for some enhancements or those with anterior basement membrane dystrophy. We all know the story and the studies by Dan Reinstein showing that SMILE versus LASIK, there's less dry eye, there's less of an overall decrease in corneal sensation, and there's a faster recovery. We're also familiar, of course, with the steps of lamellar dissection here, and therefore we can talk about complications. I'm not going to discuss infections, as that could be an entire symposium on itself, but we'll go ahead and discuss all of these different complications here. With suction loss, if there's a suction loss later in the procedure, during the cap or incision, you can simply redock and continue. The reasons for suction loss would be a wet corneal surface. I'm always sure to dry with a little Muracell sponge right before I do the docking in the fornices, just slight dabbing, and this helps to decrease the incidence of suction loss. Of course, if you have eye movement, a nervous patient, this can also be an issue. I also talk to them all during the procedure. I'm reassuring. I tell them to look at the light. I tell them not to be concerned when the light disappears. And verbal anesthesia and constant reassurance can also help. Of course, now with the new Visumax 800, which you have had here in India for longer than I've had it in the US, there's shorter treatment times now, less than 10 seconds, and therefore with the under 10 seconds, it makes suction loss really pretty much a thing of the past. I don't always dress in a hyena outfit to do my surgeries. This was at the AIOS meeting. For those of you who have not been there, you are required to wear a costume during your presentations, and they provide them nicely for you. Difficult lenticle extraction, so if you make it through not having a suction loss, what can happen? And I was actually just teaching SMILE yesterday here in Delhi, and to some of the newer surgeons, fellows, and just out of fellowship. And if you have a difficult lenticle extraction, each step prepares you for the one next. And if you have meibomium secretions, or you have anything that's on the patient interface device, or you have something, epithelial disruption, then this will be translated into the SMILE procedure itself and can lead to difficulty with lenticle extraction. So if there are debris in the tear layer, you'll get these skip areas, and the thing is to not do anything if you have those meibomium secretions in the first place. You want to wipe them off, rinse them off, and redock again. If there's scars in the area of the SMILE treatment zone, offer LASIK or PRK, because any kind of opacity, as we know, with the femtosecond lasers will cause the pulses not to go through. And so if there is a small scar that is significant enough in the smile treatment zone, then I opt for another procedure. If it's outside of the smile treatment zone, you can then, of course, continue. You need to identify, of course, the anterior and posterior planes, and especially in first getting started, of course, I'm talking to a room full of experienced smile surgeons here. However, when I train the fellows and or new practitioners to smile and let them know that it's really, really common to think you've dissected anteriorly, but you've dissected posteriorly, and to do this anterior rescue maneuver, get really, really anterior with that tip, and then you will find your plane. A lot of times people say, oh, I think I dissected anteriorly, however, I can't find the posterior plane, and I would say that 9 times out of 10, you in fact have dissected posteriorly first. For thicker corneas, I actually bump up the energy by 1 step, and so when looking at the energy settings under expert mode, what I do is if it's above 580, I bump it up 1 step, which is equal to 5 millijoules, and you have to do that all across. You need to, of course, balance your energy with your OBL. If you have a retained lenticle, the nice thing to do is to go back and get that, start from the middle dissecting, and then you can go ahead and lift the end, and usually comes right out. If it's small, and this was a case where I had done a smile procedure right before COVID, right before the world shut down. I didn't see the patient until almost 1 year later, and they had this very small little area at the blue arrow with a retained lenticle. I could not get into the smile interface at that point. I did a PRK, and that tended to work well. DLK with smile versus LASIK tends to be patchy rather than diffuse. I recommend rinsing earlier. If you do a PRK after smile or LASIK, I actually prophylactically give them a 5-day course of oral steroids. I give 40 milligrams of prednisone. You can either do it for 5 days or 40 for 3 days and then 20 for 2 days. Interface fluid syndrome, similar to PISC, it can mimic or coexist with DLK, and so sometimes what will happen is you'll have a DLK and then you start the steroids and you wonder why they're not getting better, or there was initially they were getting better and then they didn't, and in fact you can have a case of interface fluid syndrome. Of course, just like with PISC, we treat with IOP lowering meds, and keep in mind you want to minimize steroids. In the case of epi-ingrowth or implantation, this is another thing that can occur. If it's with smile, most likely it's actually epi-implantation. You introduced the epithelial cells during the procedure versus LASIK, where it's most likely ingrowth, meaning that there was in fact a channel for the epithelial cells to go in. You want to go ahead, and you'll see this in smile, you'll actually see it early. And go ahead in, this was a case I had. I obviously had introduced some epithelial cells inadvertently. And I went in with a little Sinsky, and you can see the before and after. This is a case of LASIK. If you have regressed epi-ingrowth, sometimes you'll see this years later. If there's a demarcation line, no worries. If, however, it has appeared, then one thing that I like to do is, in fact, a YAG treatment for it. This is a case of flap dislocation from trauma. We've all seen these, and there was irregular astigmatism. You want to make sure you replace the flap as best you can, and then after replacing the flap, you can treat the ingrowth with a YAG as needed, and then if needed, you can do some PRK to correct the refractive error. And of course, no complication talk would be complete without mentioning avellino-corneal dystrophy after LASIK. I don't really see a lot of it in my area. There is testing for it if you have a lot of that in your area, and that's something that can be considered. So I want to thank you so much for your kind attention, and thanks for inviting me here. It's a pleasure always to be back in India.
I just wanted to ask one question, ma'am. Sometimes, despite being paranoid about not having microstriae when ironing it out, I sometimes, very rarely, particularly in patients where I'm ablating a lot, I will tend to see them, very fine ones. and it tends to bother only a few patients, not all patients. So how aggressive should I be if I see those microstree in the central cornea to take them back into the OR to maybe flatten them, or should I just tend to leave them?
I'd say most cases, they truly are microstria and they're not going to be significant with LASIK. On the table itself, with LASIK or with SMILE, right after, I do actually, with a wet Muracell sponge, make sure I try and, smooth, do what you can. Of course, especially you'll see this in the higher myopes. But I'd say it's rare that a patient, I think it usually bothers the surgeon more than the patient. If it's more than that, though, then sometimes you do have to take them back. But unless it's bothering the patient, I really would count it as 20 over happy.
Thanks a lot, ma'am.
Great. Thank you so much.